So let's dive straight in. So as I said, this is our first respiratory webinar. So we're going to be covering two topics, asthma in adults and lung cancer. So we use a case-based approach to all of our learning, mainly because having been through medical school, been through a lot of what you guys are going through already, we believe that this is the best way to learn medicine and translate it into clinical practice as well. So we're going to identify our top differentials, why these are, cover basic things like pathophysiology, diagnosis, etc. And then we also use our interactive quiz software called Mentimeter, if you guys aren't aware or haven't watched one of these before. So feel free to kind of get your phones out and we'll run through all of those interactive quizzes as well. And the final thing here is this concept of multi-step single best answer questions, where we kind of go through the whole journey of a patient and we answer questions along that entire journey in order for us to get a better understanding of the entire patient experience. So on our platform, which is coming out in around a week or so, or 10 days, we're going to have a whole bunch of questions just like that, and a whole bunch of new webinars, etc. as well. So keep an eye out for that as well. So let's jump right in. And also one last thing is in terms of questioning, I'll try and answer a few questions in the chat as we go along, but we have a whole bunch of fabulous doctors in the chat as well who'll be able to answer your questions. We also take account of all the questions that are asked in the chat and the Q&A, and we'll answer those in a separate PDF at the end, so everyone has those answers. So hopefully all of that makes sense, and let's dive into our first case. So case number one. We have a 29-year-old male who has presented with shortness of breath and wheezing after exercise. He's presented to his GP. His symptoms have been getting progressively worse over the last year, and he's been struggling to sleep at night as well. So there he is, kind of puffing away a little bit, and his lungs are there, in case you don't know what lungs are. So observations. So here are his basic observations. Got a heart rate of 98, blood pressure, respiratory rate, saturations, and his temperature. Anything worrying or concerning you guys based on those observations at all? Nope. Nope. Good. Yeah, I mean, I'd say they're pretty fine. I wouldn't be really worried about any of those, to be honest. Good. So we've got a basic idea of what he's come in with. Imagine you're sitting at your GP surgery, and this is the chap that you're seeing. So as we know, we think that this guy might have asthma. So let's have a look at our first question. So if you guys could go to www.menti.com and type in this code, 881971, and we can answer this question. So which of the following mechanisms is implicated in the pathogenesis of asthma? Classic, nice, simple question to ease you guys in, very commonly asked in exams. So which of these do you think it is? It's IgE mediated, what kind of cells are involved as well? And I'll give you a few moments to answer that one. Okay, see what you guys think. Okay, fine, brilliant. That was a nice simple question. The majority of you think it's IgE mediated activation of mast cells, which is absolutely correct. So well done to all of you guys, and we're going to run through the pathophysiology of asthma now so that the rest of you get a better understanding, and all of us get a better understanding of the pathophysiology of asthma. So let's have a look. So the definition of asthma really is chronic inflammation which results in reversible airway obstruction and hyperreactivity. So if your consultant or your registrar ever asks you for the definition, that's a brilliant definition because it covers the main points here. So when we say reversible airway obstruction, what we mean is that when you give bronchodilators to these patients, generally that should cause the airways to open up and relieve the patient's symptoms and improve their spirometry. Hyperreactivity just means that these patients generally have a degree of genetic susceptibility to certain things in the air, allergens, irritants, pollutants, etc., which their airways are responding to. So as you can see in this picture, figure A shows this chap with his lungs. Figure B shows a normal airway, bronchi, the smooth muscle surrounding that airway. And then during your asthma symptoms, the cross-section there shows your tightening of those airways with the muscles constricting and inflammation as well. So that is the main processes that are underlying your asthma. In a little bit more detail now. Obviously, like lots of conditions in medicine, we don't fully understand every single step involved in asthma. But this is the basic pathophysiology that we think is causing asthma. So the three main aspects are bronchial inflammation, bronchial obstruction, and bronchial hyperresponsiveness, like we were talking about on the previous slide. So the main trigger behind all of this is your activation of your T helper type 2 cells. So when your extrinsic antigens come along, smoke, dust mites, whatever it may be, that's your allergen with those antigens. They cause an overexpression of your Th2 cells. This then releases a whole bunch of cytokines, interleukin 3, interleukin 4, 5, etc. This then causes activations of a cell called eosinophils. These are a type of cell in your blood involved in your immune system. These are then activated. There's also IgE production, which is a type of immunoglobulin, which causes cells called your mast cells to degranulate. And these mast cells produce a whole bunch of different inflammatory mediators like histamines, leukotrienes as well. And ultimately, this is what causes your bronchial edema and your smooth muscle constriction. And the reason why this is so important is because it really underlies the mechanisms behind almost all the drugs we use in asthma. So our bronchodilators are trying to open up your airways to reduce the bronchial obstruction. The steroids we use are trying to reduce the inflammation. Anti-leukotrienes are targeting the leukotrienes which are being produced by your mast cells. And then for your general allergic symptoms as well, we've got antihistamines, which kind of also produced by mast cells and get to dampen down that process. So if you get a good understanding of this, you really know how our drugs work as well. Does that make sense to everyone in terms of the basic pathophysiology? Fantastic, good. So a couple of classifications. So asthma is broadly classified into extrinsic and intrinsic asthma. So the majority of cases that we always talk about are allergic asthma. This is often caused by some type of allergen, and it's IgE mediated type 1 or immediate hypersensitivity response. This causes your mast cell degranulation and histamine release, as we just talked about. So most patients with extrinsic asthma, they have a genetic predisposition to this airway hyperresponsiveness, and often there's a family history of atopic disease, such as eczema, hay fever as well, or even a personal history. Whereas non-allergic or intrinsic asthma, often there may actually be no history of atopic disease in these patients. These patients are often have a more chronic picture, a little bit more difficult to treat as well, and may present a little bit later on. So the mechanisms overlap between these two a little bit, but on the whole, they're not entirely distinct processes. But they say non-allergic asthma has a little bit more neutrophil involvement. And final thing about non-allergic asthma is that tests like your serum-specific IgE or your skin prick test looking at allergies, often these are negative in non-allergic asthma, but will be positive in allergic asthma. So that's a good way to kind of distinguish between the two. So yeah, hopefully all of that makes sense. So some key differentials to try and, when you've got a patient, whether it's in the GP, whether it's in the emergency department, wherever, is to distinguish asthma from other causes of, cough, wheeze, etc. So like we just talked about asthma, these patients often present with wheeze, some kind of cough, shortness of breath, with specific triggers. When we say diurnal variation, what we normally mean is that these symptoms are worse at night and worse early in the morning. So that's a key feature of asthma, which helps to differentiate it from all these other causes as well. And it's reversible airway obstruction, like we were talking about. So you give bronchodilators and those airways open up. Now, that's in contrast to COPD. These patients will have normally a long-standing smoking history. You have shortness of breath with or without a wheeze, and this is progressive, irreversible airway obstruction. So what that means is that when you give bronchodilators, your symptoms often don't immediately disappear, and your spirometry doesn't miraculously improve. This is there's irreversible airway obstruction. Often you will have a degree of reversibility, but not to the extent of asthma. So that's why we still give bronchodilators and nebulizers to patients with exacerbations of COPD, but kind of the hallmark is that it's irreversible obstruction. We then have alpha-1 antitrypsin deficiency, which some of you may have heard of. It's a genetic condition. So this alpha-1 antitrypsin, it's a substance, it's a protein which is produced by the liver, and it's designed to protect your lungs against something called neutrophil elastase. So in these patients who have a deficiency in this alpha-1 antitrypsin, their lungs get damaged. So these patients often present quite young with symptoms essentially corresponding to COPD, but often without a smoking history. And they may have a family history of early onset lung disease as well as liver dysfunction. So that's how you can differentiate alpha-1 antitrypsin deficiency from the other two. And then finally, bronchiectasis. Patients often have recurrent pulmonary infections. It's associated with cystic fibrosis, for example. They have enlarged airways. Their airways get all clogged up with mucus, and they get these recurrent infections. So the presentation is slightly different in that they often present with really mucky, purulent sputum. And when you investigate them, you can do a CT, and that will show your bronchial wall thickening. So that's a good way to kind of differentiate between those four causes. Everyone keeping up with me so far? Make sense to everyone? Brilliant, good. All right, moving swiftly onwards, let's have a look at this question. So according to NICE, what is the first line management, or the most appropriate investigation in this stable patient with suspected asthma? So this chap's come in, you think he might have asthma. According to NICE, what's the most appropriate first line investigation out of these options? A bit of a tricky question. So we are working on NICE guidelines, and I'll have a chat with you on the next slide a little bit about the difference in the guidelines in the UK. So let's see what you guys think. Okay, peak expiratory flow rate is what the majority of you are saying. Okay, so it looks like we're going to need a little bit of teaching on the first line investigation, or the investigation of asthma according to NICE. So the actual answer here is fractional exhaled nitric oxide. We're going to include all the NICE guidelines to asthma. Obviously, you can look these up yourself, but we're going to work our way through NICE and what NICE think about the diagnosis of asthma. So there are differences between guidelines. So the British Thoracic Society have a very different view to what NICE say. So British Thoracic Society say that if a diagnosis of asthma is highly probable, you generally do spirometry, and then you can start treatment and monitor. And if you've got a high clinical suspicion, you can treat them for it and see how things go, which in my view is a very pragmatic approach, and often what actually happens in clinical practice as well. But often in your exams, you're going to be asked about NICE guidelines, or you're going to be asked about more specific stepwise diagnostic approach to asthma. So according to NICE, this is what you do. So the first thing you need to do is measure something called fractional exhaled nitric oxide and perform spirometry. So what FeNO is, or fractional exhaled nitric oxide testing does, is essentially it's a simple test where you're measuring the amount of nitric oxide produced by your lungs. When you have lots of inflammatory cells like eosinophils, they produce loads of nitric oxide, and if it's above 40 parts per billion, NICE say, that's a pretty positive test, and that shows there's some underlying inflammation going on in your lungs, and that indicates asthma. Alongside that, you're going to do spirometry. And as I'm sure you guys know, asthma causes an obstructive picture on your spirometry with a reduced FEV1 to FVC ratio of below 70%. So you've done those 2 investigations. So that's what we would have done with this chap. So based on your spirometry, if the spirometry shows obstruction, like we just talked about, we then do something called bronchodilator reversibility testing. So that's when you give a bronchodilator to these patients and you see if there's an improvement of their FEV1. So like we said, asthma is reversible airway obstruction. So NICE say if there's reversibility of more than or equal to 12%, that is suggestive of asthma. So the easiest way, the easiest kind of route to diagnosing asthma is FeNO raised, spirometry obstructive, and bronchodilator reversibility positive. You can diagnose asthma. So the other pathway is going to be, you do your FeNO and your spirometry testing. If spirometry does not show obstruction, you then do your peak expiratory flow rate testing. So like a lot of you guys said, you'd do that earlier on. Actually, it's done relatively late. So there's no obstruction on your spirometry. You then do regular peak expiratory flow rate testing. So you want to monitor your peak flow variability over a period of 2 to 4 weeks. If there's a variability of over 20% throughout the day, that's a positive test. So this is a very simple kind of pathway. It gets a lot more complicated further down the line. But if you remember this, so FeNO and spirometry demonstrate asthma, bronchodilator reversibility suggests asthma, you can diagnose asthma. If FeNO is positive and spirometry shows obstruction, you then do peak expiratory flow rate testing. And if there's variability, then you can diagnose asthma. So that is actually the very basic kind of initial steps in asthma diagnosis. And if you remember those, you're doing really, really well. The only other couple of tiny things I wanted to mention is that obviously this gets a lot more complicated. So like, what if your FeNO is slightly low, but not normal? What if your spirometry is inconclusive, for example? Then you can do another test called airway hyperreactivity testing. This is essentially where you give nebulized histamine or methacholine to act on your bronchi to see whether they bronchoconstrict. And if that's a positive test, then that can also help you diagnose asthma as well. But that's done further down the line, often in kind of specialist environment. And then kind of a general investigation is that may be useful in some patients with allergic asthma, is going to be your allergy testing. See if there's some specific allergies that you can pick up. So this is your diagnostic pathway for stable patients that you suspect have asthma. So this is really, really good way to remember it. And if you remember everything I've said on this slide, honestly, you'll be doing absolutely fantastic, not just in your exams, but also when you get into your foundation years. This is actually more than what a lot of doctors in their foundation years will even know about asthma. So brilliant. Everyone keeping up with me? Make sense to everyone? Brilliant. Okay, good. I know there's a lot to take in, so make sure you guys go over the slides afterwards as well. So that was kind of a stable patient with asthma. So what are we going to do if a patient comes in with an exacerbation of asthma? So these patients, they're puffing away, wheezy, breathless, coughing, and they just look awful. And you're in the A&E department and you're assessing them. Well, let's follow this approach: bedside bloods imaging. The bedside test, peak expiratory flow rate. And these are a few cutoffs that you guys should be aware of. Most importantly, is probably going to be your life-threatening below 33%. Some blood tests, general blood tests, full blood count. Are there any markers of inflammation that are raised? Arterial blood gas, it may demonstrate acidosis. It may demonstrate evidence of respiratory failure as well. And then a chest X-ray. So hyperexpanded chest, classic in patients with asthma, classic in patients with COPD as well. And there may be some focal signs like evidence of consolidation, for example. So yeah, those are the actual initial investigations are quite straightforward for patients with an exacerbation of asthma. So let's have a think now. Let's have a look at the next question. So we have a patient now, let's say he's come into A&E, the emergency department, with an exacerbation of asthma. Which of the following is a life-threatening feature of asthma? Have a look at your options, see what you think. Which of the following is a feature of life-threatening asthma? Okay, so what do you guys think? Okay. PaO2 of 7.8 is a life-threatening feature of asthma. So once again, a tricky question. So let's have a think about why that is and how we differentiate between the different classifications of asthma. Here are your levels of severity. I try and remember the main points here. I'm not going to go through every single one of these, but when you get to foundation level and beyond, these are really basic things that we kind of need to have a good understanding of. So moderate, worsening symptoms, but not horrific. Peak flow 50 to 75. Severe, as you can see here, the one that most of you put, which is unable to complete sentences in one breath, is actually a sign of severe asthma. You then have life-threatening, which is kind of any one of these clinical signs or measurements. And this is really important to be aware of, because obviously when you get a really, really severe or life-threatening asthma exacerbation, these patients are puffing away, trying to get as much oxygen in and blow off as much CO2 as possible. They're going to eventually get exhausted in life-threatening attacks. So as they slowly get exhausted, their respiratory rate, they lose that respiratory effort because they're getting so tired. Their chest goes silent, they have poor respiratory effort, they can become cyanotic. And that is why when your PaO2 is below 8, so your normal PaO2 is kind of 8 to 10, once they're actually becoming even marginally hypoxic, you're thinking, is this life-threatening? Because these patients should be puffing away and maintaining their own respiratory effort. But they're getting so tired that actually their PaO2 is dropping. And if they have a normal PaCO2, that's also very worrying, because these patients should be puffing off all of their CO2. So actually it should be low and the PaO2 should be normal. So once you get into the point of kind of near fatal asthma exacerbation, then we're thinking high PaCO2, becoming hypercapnic, or they need mechanical ventilation. So try and remember these general features. I think it makes a lot of logical sense. So yeah, that's good for you guys to remember. So let's have a look at the next question. So the codes for the questions are at the top. Oh wow, okay. Bring that down. All right. So yeah, the code's 881971. So the patient's diagnosed with asthma. So our nice chap came into the GP surgery. You diagnosed him with asthma after all of those tests. You remain symptomatic despite salbutamol and beclomethasone inhalers. What is the best next management? Now, what are you going to do next for this chap? You've tried salbutamol, you've tried beclomethasone. Okay, let's have a look. Good. Okay. So you 44%, you're absolutely right. So add montelukast. So montelukast is an anti-leukotriene. We're going to go through the stepwise management of asthma according to NICE on the next slide. Tiotropium is your antimuscarinic. It's not used in asthma, it's used in COPD, and it's not any of the other options, and I'll show you why right now. So essentially learn this slide. This is the stepwise management according to NICE. The British Thoracic Society guidelines are a little bit different. So they vary in terms of step 3 and step 4. But all patients are going to be started on a PRN salbutamol. So that's a short-acting beta agonist. You then add to your short-acting beta agonist, you add on a low-dose inhaled corticosteroid, such as beclomethasone. So that chap, when he came to you, was on step 2. Step 3, you'd then add on to that a leukotriene receptor antagonist, which, if you remember our pathogenesis, that's targeting that step from your mast cells. It's trying to reduce the production of those. And then you trial that and see how that's getting on. You then have short-acting beta agonist with your low-dose inhaled corticosteroid and your long-acting beta agonist. If your leukotriene receptor antagonist, so your montelukast, isn't doing a good job, you can stop that and just add on a long-acting beta agonist, such as salmeterol. And this is where the BTS guidelines switch as well. So they do step 4 instead of before step 3, whereas NICE do step 3 and then step 4. So in your exams, generally NICE is what's preferred. which is what this pathway is. Step 5 is then a short-acting beta agonist such as salbutamol, with or without a leukotriene receptor antagonist, depending on whether they're effective earlier on. And then this is a key point. So this is regardless of whatever guidelines you use, you need to be aware of this concept of a MART. So a MART is a maintenance and reliever therapy. So MART is a combined long-acting beta agonist and a low-dose inhaled corticosteroid. So up here, you're using, an inhaled corticosteroid / long-acting beta agonist, so in 2 separate inhalers. Step 5, all you're going to do is combine those two. So what that means essentially is MART is that you use that inhaler when you're symptomatic as well as for maintenance. So that means in these patients, whether they're symptomatic or maintenance, they can use a MART. So that's often a combination of a fast-acting, this is where it gets a little bit confusing, a fast-acting, long-acting beta agonist. So often like formoterol plus an inhaled corticosteroid in this one inhaler. So an example would be Foster. So you just switch these 2 separate inhalers into one inhaler, and an example of that would be Foster. And then finally, you're getting into step 6, step 7. It gets a little bit even more complicated, where you start changing the doses of your inhaled corticosteroid. So yeah, that's the pathway. I would learn that and just be aware that BTS say step 4 instead of step 3. You switch them around. But yeah, if you remember that, you'll be absolutely fine. In exams, often it's difficult to ask questions like this because there are 2 major guidelines. But as long as you know NICE, you can generally be pretty confident. Good. So finally, kind of management of an exacerbation, really straightforward, much simpler than the management of a stable patient. This is your bread and butter in A&E or resus. General, you're going to give all patients with life-threatening asthma or oxygen saturations of below 94%, you're going to give them oxygen, often via a non-rebreathed mask. We're then going to give normally nebulized salbutamol is going to be your first line. To try and open up those airways, they can be given back to back. So often you'll give kind of 5 milligrams of salbutamol, 1, 2, 3 times in a row, and then you can add on ipratropium bromide nebulizer as well, which works by a different pathway, it's antimuscarinic, which can try and kind of augment the effects of salbutamol as well. Then corticosteroid as well, we're going to add on, so oral prednisolone or IV hydrocortisone if they're not alert or unable to tolerate oral intake. And then one point I just wanted to make you guys aware is that steroids, a lot of people think these patients, you give them a steroid and they're going to miraculously get better, but they take a few hours to work even if given intravenously. So this is to try and stop that inflammation over the next few hours. It's not suddenly going to reduce your inflammation. And then the severe and life-threatening exacerbations, we've got to think about intravenous bronchodilation. So classic exam question and classically in clinical practice, you'll get a patient you've given salbutamol to, you've given ipratropium to, you may have already given a steroid, and they're getting worse and worse. The next thing you need to do is give an IV magnesium sulfate. So that's really good in your severe or life-threatening exacerbations. Other alternatives include IV salbutamol and aminophylline. And then ventilation. So this is a quick story I wanted to tell. So when I was at F2, I did a resus night shift, and I had a patient who'd come into resus with a moderate asthma exacerbation. He was doing pretty well. We gave him some back-to-back salbutamol nebulizers, like we've talked about. We gave him some ipratropium bromide, giving him some steroids, some oxygen. And by the end, after I was done with him, he was sitting up nice and well, chatting, laughing, having a good time. So I told my registrar that I was going to go on my 15-minute break. I went for a break for 15 minutes, and I came back, and anesthetists were there. The bed was flat. He was being intubated and getting taken off to resus. So the point I'm making there is that this patient became critically unwell in such a short period of time that you can't underestimate that. So even though you've given all of this, you've given magnesium, they can deteriorate just like that. So you need to observe them. And at that point, they may need ventilation if things go downhill despite all of this. And then finally, if you think this is an infective exacerbation, then you can consider antibiotics if you think it's bacterial. Does the management of exacerbations make sense to everyone? So, you know, oxygen, nebulizers, steroids, bronchodilators, ventilation. Good. That's a real crash course. To be honest, that's all you really need to know for exams and for, you know, F1, F2. Good. So, well done, everyone. So, summary of asthma. We know how it presents. We know there's diurnal variability, as we said. According to NICE, pheno and spirometry are our first-line investigations. You can also do these other fancy tests: bronchodilator, reversibility, peak expiratory flow rate. First-line treatment we now know is, you know, short-acting beta agonist, followed by inhaled corticosteroid, and then following that pathway, like we've talked about as well. I really wouldn't get bogged down on NICE versus BTS. Learn one of them, and it's very unfair in your exams unless they've told you beforehand to follow one or the other. It's unfair on them to ask you the third line in management without classifying which guideline to follow. But I would probably recommend using NICE and just being aware that BTS just differs in terms of those third and fourth steps. And then, you know, finally here, acute exacerbations, generally managed with bronchodilators and steroids, like we talked about. Good, so that is a whistle-stop tour of everything to do with asthma, basically. We've taken a pretty complex topic and hopefully given you all the most important bits. And our doctors, I can see, are answering a lot of your questions as well. So if you guys are happy, we can move on to lung cancer. So let's do that. Good. So case number 2. We're moving away from asthma towards this lung cancer case. So we have a 62-year-old chap presented with a 1-month history of coughing up blood. He has felt generally lethargic recently and mentions that his clothes are feeling loose. On examination, as you can see here, these lovely, beautiful graphic we have here of tar staining on his fingernails. And you know, some routine bloods are taken, and as you can see here, these are what his blood tests show. So have a think of the history, have a think of what these blood tests may reveal. And there he is, he's got blood in his tissue as well. So there's only really one abnormality here, really, one major abnormality, but have a think of what that means. And let's pop onto the next slide and see how we can put all that together. So putting the history and those blood tests together, I think it's the same code. If not, you may need to pop that one in 441081. So based on the history and those blood test results, which if you don't remember showed a low sodium, what is the most likely diagnosis? Give you a few moments. Squamous cell carcinoma, small cell lung cancer, adenocarcinoma, large cell carcinoma, or a carcinoid tumor. What do you guys think? Small cell lung cancer. Okay. So the majority of you think that. I'll let it get up to 200. Okay, you're absolutely right. Small cell lung cancer. So we're going to explain a little bit about that in the next couple of slides, but a brief summary here is that small cell lung cancer is associated with a paraneoplastic syndrome called syndrome of inappropriate antidiuretic hormone secretion, or SIADH. You get excess retention of water because of that, and that causes your dilutional hyponatremia, so your sodium drops. So it's not due to like a sodium deficiency, it's because that sodium is being diluted. And that's a feature of small cell lung cancer. So we're going to talk through all the different paraneoplastic features so that you guys can smash it in your exams. Good. So etiology, majority of lung cancers are primary bronchial carcinomas. Our key risk factors are, well, the most important risk factor is going to be smoking. The vast majority of cases are going to be of lung cancer are going to be due to smoking. But also remember your common other risk factors: family history, asbestos exposure, as well as increasing the risk of mesothelioma can increase your risk of lung cancer as well. Pollution, radon exposure, and idiopathic pulmonary fibrosis. Key risk factors, as I'm sure you know, the most important one is smoking. So tell all your patients to quit smoking. And if you're smoking, you try and quit smoking too. So classifications. This is how we're going to differentiate between our small cell and non-small cell lung cancers. The small cell accounts for 15% of lung cancers. It's derived from your neuroendocrine Kulczycki cells. Very nice name, Kulczycki cells. They grow rapidly, patients present late, which means these patients, I don't want to give away the answer to the next questions, but just remember they present quite late. And non-small cell lung cancers make up the majority as well of lung cancers. So that accounts for squamous cell adenocarcinoma, etc. So that is, we've got a nice table coming up in a few slides to help you guys remember the difference between the two. Okay, next question. So which of these cancers is most common in non-smokers? We're going to talk about Lambert-Eaton in a second. I can see that popping up in the questions. Which of these cancers is most common in non-smokers? Squamous, large cell, adenocarcinoma, small cell, or carcinoid? Give you a few moments. Let them get up to a couple of hundred at least. Okay. Okay, a little bit of a split. But the majority of you are saying adenocarcinoma. Absolutely right. The lung adenocarcinoma is the most common type of lung cancer in non-smokers. So that's just a good fact for you to remember. Often comes up really, really common in exams. And carcinoid tumors are kind of neuroendocrine tumors, which often kind of occur in the GI tract, but also can occur in the lungs as well. Good. Okay. So we touched on the phrase paraneoplastic syndrome earlier. But which of these paraneoplastic syndromes is associated with small cell lung cancer? Diabetes insipidus, Cushing's disease, hyperparathyroidism, polycythemia, cerebellar syndrome. Okay. Wow, that really was a tough question. So let's have a chat about this. So the correct answer, because this was a bit of a trick question, is that actually out of these, small cell lung cancer causes cerebellar syndrome. The cerebellar syndrome is basically, it's a paraneoplastic syndrome, and it causes your characteristic features of cerebellar disease like ataxia, imbalance, etc. Now, these other options, it's not associated with diabetes insipidus. Diabetes insipidus can be caused by a whole host of different things, but not generally small cell lung cancer. Cushing's disease, now this is where the majority of you got caught out on. Cushing's disease, that's when the ACTH is coming from the pituitary itself. Remember, small cell lung cancer causes Cushing's syndrome, ectopic ACTH production, not from the pituitary. Yeah, it's pretty savage, so that was a good question. I must say so myself. Hyperparathyroidism, almost, but not quite. So small cell lung cancer causes the release of PTHRP, or parathyroid hormone-related protein or peptide, which acts like, almost exactly like parathyroid hormone, but it kind of acts on bone and it acts on like the kidneys. So it absorbs calcium, and it resorbs bone to produce more calcium. So you get hypercalcemia, but it doesn't actually cause hyperparathyroidism because it's producing this analog of parathyroid hormone. Yeah, it's not associated with polycythemia. So here's a reasonable table for you guys to hopefully be able to remember all of those paraneoplastic syndromes and a little bit about the associations. Small cell, often central, as is squamous cell. The other two are often peripheral. Obviously, this can differ a little bit. But yeah, on the whole, those are the locations. Smoking, on the whole, has a strong link other than adenocarcinoma, which is less associated with smoking. And then these are your paraneoplastic syndromes. So SIADH, like we talked about, Cushing syndrome, Lambert-Eaton and small cell lung cancer, like we were talking about before. So this is when you have your antibodies to your presynaptic voltage gate calcium channels, and it causes, your weakness, your non-fatigable weakness. So that's how kind of one of the features that differentiates it from myasthenia gravis. And then cerebellar syndrome, like we talked about. Non-squamous cell lung cancers associated and can cause hypertrophic pulmonary osteoarthropathy. Essentially can cause kind of finger and toe clubbing, and you get kind of swelling of your joints, essentially. And like we talked about, parathyroid hormone-related protein can cause hypercalcemia in squamous cell lung cancer. Does that make sense to everyone? A little bit more about, so that's a bit about the pathophysiology and a few of the paraneoplastic syndromes as well. Everyone happy with that? Yeah. Okay, good. Glad it's coming in handy. So, cancer referral pathway, this is super important for exams and really important for your F1, F2 and beyond, particularly if you're working in general practice and in A&E. So essentially remember this straight from the NICE guidelines. Refer the cancer referral within 2 weeks if you have a chest x-ray which suggests lung cancer, or you're over 40 years old with unexplained hemoptysis. And you do an urgent chest x-ray within 2 weeks if you're over 40 years old and have 2 of these symptoms, fatigue, cough, etc. Or you have a past medical history of smoking, past history of smoking, and 1 of these features. Really straightforward points to remember, really important for exams and for clinical practice. If you follow these, you're very likely to, well, at least if you follow the guidelines, you're more likely to pick up these malignancies earlier on and, increase the likelihood of you actually diagnosing cancer while it's still treatable. So cancer referral, like we said, is these 2 bullet points: an urgent chest x-ray for above 40 years old and 2 of these, or smoker or previous smoker and 1 of these features. Brilliant. So investigation. So bloods you can perform, but not necessarily diagnostic, but may reveal features of some of your paraneoplastic syndrome. So, your hyponatremia, like we talked about in SIADH, you get hypercalcemia, like we said as well, due to parathyroid hormone-related protein. You do some imaging. So chest x-ray is going to show a coin lesion, and I'll show you what that looks like in a moment. CT chest x-ray is abnormal. Particularly, you can do a CT chest and image the abdomen as well if you're considering staging. PET-CT is used in staging as well, so that's kind of your radioactive nuclear medicine scan, picks up rapidly replicating cells, so that's really useful as well. And a few special tests, and I'm going to show you the exact pathway summary that we did for NICE as well to help you with knowing when to do each of these. Special tests: percutaneous biopsy if it's peripheral, or an endobronchial ultrasound if it's central. We essentially put an ultrasound probe down the trachea into the lungs where you can visualize and biopsy a central lesion. And then consider mediastinoscopy as well if you want to assess lymphadenopathy, because it's slightly more sensitive than CT. So that's kind of a minimally invasive procedure where you can visualize the mediastinum essentially. So writing it down like this is useful, but I'll show you the pathway in just a moment. And one final point is all patients, if you're going to operate on them, generally should have spirometry. Obviously, partly because a lot of these patients are going to be smokers. So FEV1 of below 2 liters, you're not going to chop out a lung, essentially. So make sure, if you get a question in your exams, which of these tests is most important preoperatively, it's going to be spirometry. Particularly if you're considering a removal of a lung, so pneumonectomy. So let me show you a nice pathway. So this is essentially what we summarize from NICE guidelines. Do a chest x-ray, abnormal chest x-ray or ongoing symptoms. You do a CT chest, lower neck and abdomen. This is actually explicitly what the guidelines say now. In reality, I would probably just do a CT chest, but this is what the guidelines say, so it's probably best to learn that. You then have a look at your lesions. If it's peripheral and below 10 millimeters, then you do PET CT, and you could do image guided biopsy. So, you know, transthoracic, classic using CT. Or if it's central, or if it's peripheral above 10 millimeters or equal to 10 millimeters, then PET CT and that endobronchial ultrasound and needle aspiration that we were talking about. But yeah, suspected lung cancer, you're always going to do a chest x-ray first. A simple investigation, minimal radiation involvement. So yeah, hopefully that makes sense to everyone. And it's a nice, simple path. Well, we think it's simple anyway, nice, simple pathway to remember what to do if you're trying to investigate suspected lung cancer. And here's a nice chest x-ray. As I'm sure you can all see, there's your coin lesion right there, boom. So that's worrying, and that's when you move on to your next steps here. So if you saw that, for example, you're going to move on to your CT. And if you then did a CT, you might find that. So that's a nasty looking lesion there as well. Brilliant. So investigations, so you've done all those investigations and it confirmed small cell lung cancer. Which of the following is the most likely management option? Which of the following is the most likely management option? Cisplatin, pneumonectomy, lobectomy, lung transplant, or you're just going to resect this tumor? What do you think? Give you a few moments. Okay. So the majority say cisplatin. Some of you say lobectomy. Correct answer is cisplatin. So really what this question is testing you. So cisplatin is a form of platinum-based chemotherapy. Obviously, this is a simplified question in that, you know, every patient should be managed, you know, as an individual, et cetera, but like we talked about before, patients with small cell lung cancer often present with very advanced disease, maybe metastatic, and is generally associated with a poor prognosis. So only a tiny, tiny proportion of these patients are going to be suitable for surgery. So that's why the most likely management option in this patient is going to be chemotherapy rather than any of these other options. Certainly not a lung transplant or resection. Yeah, but we'll talk about the exact indications for when you may consider surgery in a patient like this, but it's only a tiny proportion of patients. Okay, moving on. So the management, let's have a think. So in general, non-small cell lung cancer is managed surgically with relatively good outcomes. Small cell lung cancer is treated with chemoradiotherapy. And as we said, it's often too advanced once you diagnose the patient to actually be suitable for surgery. And as I'm sure you know, smoking cessation is key for all patients and for all of us as well. So don't smoke, please. Management, small cell lung cancer. So like we said, limited disease, you know, confined to the one side of the hemithorax, you're going to give chemoradiotherapy to. On the whole, as I said, complicated, but this is kind of general guidelines. Chemoradiotherapy with your platinum-based agents like the cisplatin that we discussed previously. Surgery is only appropriate for a tiny, tiny subset of these patients with very early disease. That's kind of T1 to T2A, so really early, no real lymph node involvement, no metastasis. If you're super lucky, you may fit into this, but the vast majority is chemotherapy, radiotherapy with platinum-based agents for the chemotherapy. And then extensive disease, so it goes beyond that ipsilateral hemithorax, and elsewhere you can consider just chemoradiotherapy. But the real golden rule is you don't really operate on small cell lung cancers. Good, and then non-small cell lung cancers. So we've got a couple of options here. So non-metastatic disease, so relatively early stages as well. Stage 1, actually not even, like a lot of patients will fit into this still. So non-metastatic disease, curative surgery, so lobectomy or removal of the lung. So these patients don't usually present at such as an advanced stage as patients with small cell lung cancer. That's why surgery is often more appropriate for these patients. So you're normally going to operate on the patients that fit into this category, and you normally give adjuvant chemotherapy. So after you've operated, you can give them a little bit of chemo as well. But particularly in patients that aren't fit for surgery, for example, with other comorbidities, you can do radical radiotherapy with the intention of cure. But on the whole, surgery is preferred. And then finally, metastatic disease, so stage 3B and above, palliative with a combination of these various things: chemotherapy, radiotherapy, immunotherapy. And this table basically, summarizes that. So non-metastatic, operate with or without chemo. Metastatic, you're thinking palliative, unfortunately. So actually, this is it can be very complicated how you manage lung cancer, but this is a nice, simple summary with all you really need to know for examination purposes. So our summary of lung cancer. So non-small cell lung cancer accounts for 85% of cases, the majority of cases. We've talked about all our paraneoplastic syndromes, or the most important ones. We've talked about, things like SIADH, hypercalcemia, Lambert-Eaton, for example. We know who to refer now. So suspicious chest X-ray, equal to or above 40 years old with unexplained hemoptysis, or you do an urgent chest X-ray for this group of patients. So your threshold for doing a chest X-ray is lower in patients who have a smoking history. So they only need one of those nasty symptoms that we discussed. So staging involves all those tests that we've discussed: CT, PET, maybe an EBUS, maybe percutaneous biopsy, for example. And then we know the management now. Small cell, vast majority just have chemo, radiotherapy. Then non-small cell, surgery is the main curative treatment, often with adjuvant chemotherapy as well. That is your whistle-stop tour, really, of asthma and lung cancer. So hopefully you guys found that really useful. This is really, almost everything you really need to know for exams, to be honest, which we've tried to condense as much as possible. So as I said, all we ask from you guys is to please leave us feedback and please tell people about us. That would be really kind of you. And if you could please follow us on Instagram. We also have a Q&A after this. So if you want to stick around for a question and answer session, the question and answer session is basically about, life as a doctor, life at med school, advice and stuff. You can also ask questions about these topics, which we'll then put into our PDF as well. And yeah, if you could, this is the feedback form I repeatedly put here, into the chat. So you can, if you could please leave us feedback, we'd all be super, super grateful. You can buy our textbook online as well, at bitemedicine.com. We have our new platform coming soon, which is really exciting. So keep an eye out for that. And yeah, you can also use the QR code here to leave us feedback. So we're really, really grateful for that. If you want to get involved with some of the stuff we're doing, whether you're a med student, whether you're a doctor, whoever you are, anywhere around the world, you can email Rich, who is the head of our medical student body, at opportunities@bitemedicine.com. And if you have any questions for me specifically, either stick around for the Q&A on the next slide, or email me at azim@bitemedicine.com as well. I'd be more than happy to answer your questions.